My name is Donohue and I'm a consultant anaesthetist at the Royal Free Hospital in Hampstead. I'm principally a liver transplant and vascular anaesthetist, but I've got a lot of interest in patient blood management and obstetrics. So I'm going to talk about antenatal anaemia and an audit of practice across our trust that we did with NHSBT, and then some of the features of the Obstetric Anaemia Toolkit that we've been putting together. Okay. Briefly touch on what happens to the haemoglobin and what happens to iron during pregnancy and the adverse effects of this, and thinking about what we should be doing, what are the guidelines and what is our best practice. I'll talk through the Royal Free data, the retrospective audit that was done in 2015, and then show you some of the improvement work and new pathways that we are putting into place, and some of the education projects alongside that. And right at the end, just touch on a national comparative audit that's in the pipeline and planned in this area. So we know that there's a natural decline in haemoglobin and hematocrit because our plasma volume increases throughout pregnancy disproportionately to the increase in red cell volume. So there is a natural downward drift of haemoglobin, and hence the definitions for anemia in pregnancy are slightly different to those of the general population. And at first trimester, a haemoglobin that's fallen below 110 grams per litre is considered anemia, and by second trimester, that threshold is at 105, and postpartum 100. And then the anemia can be further defined according to its severity, severe, moderate, mild. Far and away, the most common cause of anemia in the pregnant woman is iron deficiency anemia. It constitutes 50 to 90% of cases. Then we have other nutritional deficiencies, folate deficiency, B12, the hemoglobinopathies, and other less common causes, infections, parasitic hookworm. And you can see on this map that sub-Saharan Africa, you can think of all of those causes of anemia are rife in these areas, and prevalence of antenatal anemia is 55% in these populations. In the UK, it's estimated at about 15% according to the WHO global database. So iron is absorbed from the gut via the enterocytes and enters the circulation via ferroportin channels, and it is in circulation bound to transferrin that it is functional and can get to the end organs, muscle, heart, hair follicles, bone marrow for erythropoiesis. It's stored as ferritin in the macrophages. And in absolute iron deficiency, it's either due to a deficiency coming into that system, a reduced amount of iron coming into that system, or an increased iron use due to red blood cell turnover or increased need for erythropoiesis. In a functional iron deficiency, there's an upregulation of hepcidin in the liver in pro-inflammatory states that blocks the ferroportin channels and prevents the iron from the macrophages or the enterocytes coming into the circulation to be used functionally, to be used for erythropoiesis. And in this situation, essentially, there isn't iron available to do its job, but it is there sat in the cells. In pregnancy, the iron deficiency that ensues is usually due to that increased requirement for erythropoiesis to increase the red cell mass to fuel the uterus, the placenta, the fetus, and that's normally where the deficit occurs. And the risk factors for developing iron deficiency are, well, if you start off with depleted iron stores, as Toby's already alluded to, many people, just due to normal menstruation patterns, they're coming into their pregnancy with depleted stores in about 20% of cases. If there's a short turnaround time between pregnancies, particularly another pregnancy within a year, there's no time to replete the stores and catch up, and you're already at a low ebb. Patients who are at risk of both inadequate stores and inadequate intake during their pregnancy include vegans, vegetarians, patients with malabsorptive conditions, patients who've got hyperemesis or really bad nausea and poor oral intake during their pregnancy. Pregnancy itself, as we've mentioned, places excessive iron demands. So there's a threefold increase in your iron requirement, and this increases throughout pregnancy, which is why that drift down of the haemoglobin is frequently seen. And if you have a multiple pregnancy, that requirement and therefore that deficit is even more keenly felt, and it can be very difficult to keep up just with diet alone. So antenatal anemia is a modifiable risk factor, and there are multiple adverse effects that are described in the literature. So effects on maternal morbidity, mortality, fetal outcomes and pregnancy outcomes. For mothers, there is an increased susceptibility to infection, fatigue, a host of non-specific symptoms, reduced tolerance to peripartum blood loss, and also disturbed cognition. If the anemia is severe, there's also an increased mortality effect. And Embrace, that we heard about earlier, recognised an association between women who died from hemorrhage and were anemic antenatally. The fetus is relatively protected from the effects of iron deficiency because the placenta upregulates the iron transport proteins. But there is still some evidence out there that anemia is associated with lower birth weights, preterm birth, and an increased risk of fetal anemia in the first 3 months of life, which is also associated with impaired psychomotor and neurological development in the fetus. So, what we should be telling these women. So routinely, dietary advice is extremely important, not only to raise the awareness of what iron-rich food sources to go to, but also to enhance the absorption of any oral iron supplements that are being given. Absorption of oral iron is about 15%, and that is enhanced in pregnancy up to about 30%. But as we said, if there are depleted stores at the beginning, you'll never be able to replenish those stores with diet alone. In patients who go on to need oral iron supplements, this is a great first line. It's cheap, it's about £4 a month, but it's important to know how to take them in order to optimize and maximize the success of this treatment. So women need to be advised to take them on an empty stomach, avoiding teas, milk, antacids, and taking with ascorbic acid enhances uptake, so you're taking the tablets with orange juice. Gastric side effects are dose dependent, so there's newer formulations coming out with better side effect profiles. We can consider reducing dosing regimens to a BD dosing or once a day or alternate day regimens. The constipation side effects are not dose dependent, so again it's important to think of other dietary supplements and the addition of laxatives to help really get successful oral iron treatment, because we know compliance, when we look at it, compliance of oral iron isn't great. So I'm going to talk now about some of the data that we collected in our trust, and we looked at the Royal College of Obs and Gynae, the green top guidelines, to give us our general backbone of what our audit standards were, what we were looking to see, about how our management performed. And we looked at all deliveries during October 2015 across Barnet and the Royal Free sites, and retrospectively reviewed the antenatal bloods, the management of the patients, and then perinatal transfusion practice. So Barnet is our busier obstetric unit, so they have about 6,500 deliveries per year. The Royal Free has about half that. It's a much smaller unit. I'm mainly going to talk about the Barnet data just because it was more complete as a data set and so a little bit more robust. So as you can see here, October 2015, there were 470 deliveries identified, and once we'd excluded patients who had a positive hemoglobinopathy screen or no evidence of a hemoglobinopathy screen, we were left with 433 patients. 6% of the patients were anemic on their booking screening bloods. By 28 weeks, this had increased to 14%, and of those that had bloods done at delivery on the labour ward, which it's not routinely done, so this wasn't everybody, there were 10% of women were anemic at that time point. And then in those that had postnatal FBC sent, 42% of those that had a blood test done were found to be anemic. That's about a quarter of the total cohort because, again, not everyone was having a postnatal FBC. So how were we doing? What's happened between booking bloods and 28 weeks? Well, 42% of the patients remained anemic. So that's not a success story. 38% were no longer anemic, so successful optimization there. 5 patients didn't have a repeat blood despite being anemic at booking, so that's a failing. And 50 new patients who weren't anemic at booking had become anemic, which is what we would expect as pregnancy progresses. What was really difficult to ascertain was what was being told to the patients about oral iron and dietary advice, and there was no real data on iron prescriptions and what was being given, so slightly in the dark. What was happening between 28 weeks and term? Well, again, nearly a quarter of patients remained anemic, but nearly half were no longer anemic when they were coming in to actually have their baby. Again, we lost 18 patients, didn't have a repeat FBC when they came in for delivery, and now a new bunch of patients had become anemic that were not previously. When we looked at the women who were anemic at this time point, 83% of them were documented to be on oral iron. And as you would expect, between pre-delivery and postnatal, if you were anemic before your delivery, you're going to be anemic afterwards. The reason that that's only 63% is because the rest of the cases didn't have another blood test sent, so we don't know, but we can assume that what direction it went in. But now 78 new patients have become anemic through the process of delivering, unsurprisingly. 13 patients received an allergenic blood transfusion, so 3% transfusion rate, and unfortunately, again, documentation of oral iron at discharge was really poor. So in only 7% of cases could we categorically say that the patient had been sent home with oral iron. We looked also at the transfusion practice of the 13 postnatal transfusions, and nearly half of those patients were anemic at term, and they'd all been on oral iron. We've got a fairly appropriate, that's a median hemoglobin trigger and the interquartile range there. And still, despite best efforts, nearly 70% of patients were getting a 2-unit transfusion in that postnatal period. So what is it? What factors contribute to whether you're going to get a transfusion at delivery? So there's probably 2 main criteria. And here we've looked at how your baseline, your pre-delivery hemoglobin impacts on your risk of transfusion, and separated these into the patients that were transfused and not. And you can see that the last recorded hemoglobin is statistically significantly lower in those that went on to be transfused. And what else dictates whether you're going to get a transfusion? The peripartum course and how much blood you lose during delivery. And again, looking at those 2 groups, the transfused versus non-transfused, you can see a statistically significant difference in the EBL lost at delivery. Which brings me on to the next bit, and we've talked a bit about this afternoon cell salvage, and it was really interesting to hear Celia talk about the way they use cell salvage in their institution, and I think there's much to learn from that. This is data that's from both Barnet and the Royal Free, and we've looked at all caesarean sections and the patients that lost more than 500 and less than 500 mils of blood. And you can see there that over 2/3 of patients who have an emergency caesarean section lose over 500 mils of blood. And certainly it's an area in this data set, in this 1-month snapshot, no patients had cell salvage used, and no patients got an autologous transfusion. But I think it is certainly something that we can focus on, because emergency sections are more prone to losing blood, and if you were going to zoom in on a group that might benefit, I think that's one. As it was mentioned earlier, you can just set up the basic setup, which is the suction in the reservoir, £18.50. It's a minimal outlay, and then if there's more blood collected than you anticipate, you're ready to go. And as has already been said, there's time, once you've not wasted that blood on the floor, there's time then to get the expensive kit ready and spin it and return it. The Liverpool Women's have got some nice work on this, and they now routinely use cell salvage for all of their emergency caesarean sections and all of their elective sections, apart from the very low risk ones, but they have found that is cost effective, and when they've audited it, about 20% of the collection reservoirs that they collect get spun and re-infused. So that's certainly something from this data that is interesting to look at. The other thing that was also mentioned in the previous talk was about using cell salvage for vaginal deliveries. And we know that when I looked at the massive hemorrhage rates, it's vaginal deliveries and cesarean sections, and there probably is a role for us to be extending the use of cell salvage in these women as well, and not wasting that precious blood. So to summarise some of the shortfalls picked up in this audit and also some of the opportunities that we've got to improve, we can see in this data set that there is unoptimised anaemia, and that we're not very good at documenting oral iron prescriptions and how we're advising women to best take their oral iron. What we're also missing is any evidence of a formal follow-up, so repeat bloods and assessing the response to iron, and that's really crucial in getting a grip on these women and optimising them in a timely fashion. Again, in this 1 month snapshot, no patients were documented to have received IV iron. So those patients, and possibly because they weren't being followed up in a rigorous way, the non-responders coming late in pregnancy were missing the opportunity to have their iron stores replenished ahead of time. We clearly aren't using cell salvage as widely as we could, and there's still room to embed a single unit transfusion policy in the postpartum stable woman. But I think it is also important to say that the transfusion rate in this cohort is low, and it's important to remember that optimizing maternal hemoglobin may have other benefits, than just impacting on exposure to allergenic blood and the costs associated with that. And so the potential additional benefits in terms of maternal well-being and fetal outcomes have not been looked at in this audit, and it will be really interesting to hear Charlotte's talk in a moment about how that all feeds into these other really important patient-reported outcome measures, and this is certainly something that we need to focus on moving forward. So from this, we've developed an anaemia optimization pathway to try and incorporate all of those learning points that we wanted to bring in. And really, the key emphasis of the pathway is timely detection of anemia and screening bloods 28 weeks. The empirical first-line treatment with oral iron is really important, alongside advice on how best to take effectively to maximise its effect. With prompts to follow up and repeat haemoglobin to exclude alternative causes of antenatal anaemia and confirm iron deficiency with appropriate haematinics. And where haemoglobin fails to increment, there needs to be discussion around compliance, side effects, alternative regimens, and in non-responders or in women who are approaching delivery, thinking about prescription of IV iron to replenish stores and boost the haemoglobin. We've got a rapid IV iron infusion now, Monifer, on our formulary, and this makes the outpatient IV iron infusion a much more practical matter. It can be given over 15 to 30 minutes depending on the dose, but this is compared to the 6-hour infusions that we were previously subjecting women to, not frequently, but it's obviously more expensive, but in terms of that patient's experience and also the midwifery time, logistics, space, I think it's a valuable step forward. As part of the administration and prescription guideline for the IV iron, we've incorporated helpful guidance on dosing according to haemoglobin and also the booking weight, with algorithms for appropriate management of sensitivity reactions, and also pre-printed prescription stickers to try and facilitate safe and accurate iron prescriptions. As I've already mentioned, transfusion rates were low within this cohort, so we also need to consider some of the other potential benefits of optimising the haemoglobin prenatally, not just its impact on transfusion. And patient-reported outcomes such as fatigue associated with iron deficiency and change in fatigue score with treatment might represent another important outcome measure. This is a 13-question FACIT fatigue score, which is validated to monitor fatigue in iron deficiency, though not specifically in an obstetric population. But we've just got ethics to use this as a way of monitoring fatigue in our obstetric population who do receive IV iron, to just have a look at whether there's any impact on fatigue scores. It's sort of another facet to evaluating the overall service. I think an essential part of developing this pathway and this whole project has been the education accompanying it. And much of the development of the pathway was achieved by walk-around, face-to-face sessions mostly with midwives to ascertain their opinions. They always had incredibly useful ideas and ways to tweak the pathway to make it actually practically workable. We also developed a series of lessons of the week, and many of you that work on labour wards will kind of be aware of these. These are rolling learning points that for a week at a time, every handover on the labour ward, so you've got all the midwives, obstetricians, anaesthetists, will get hammered the same lesson, and it works by repetition, and it's a really useful way of introducing a new idea or a new pathway or change. So we've done that. We've developed also a rolling programme of teaching that has encompassed PBM, oral iron tricks and tips from the haematologists, and also some practical sessions about delivering parenteral iron and managing complications on the ward. So all of this is really a work in progress, and we'll continue to collect our data prospectively to sort of see how it pans out. Trust endorsement and support has been really important, and we've recently set up a patient blood management committee, and that's very much a kind of grassroots clinicians on the shop floor feeding back into the hospital transfusion committee, but trying to support PBM projects on the ground. And one of the other things that, again, through all of this, we're trying to streamline the pathways and process is looking at reflex testing. So in patients who we would want a ferritin if they were found to be anemic, we're trying to set up an automated service so that the ferritin will automatically be triggered if the haemoglobin's low in certain specified patients that we would want to know that in. And lastly, there is a national comparative audit planned to tackle the issue of the current lack of audit data evaluating antenatal anemia management, transfusion, and maternal and fetal outcomes. And at the moment, the idea is to perhaps look at a snapshot of a single day, which would give us information on about 2,000 deliveries, but it might increase to get some bigger numbers. It's not decided. We'll collect data on the list there that you've seen. It will be the audit tool, will be refined, will be piloted, and the launch will be planned for autumn 2018. So you'll hear more about that. It'll come through the Royal Colleges and the Royal College of Midwives, who are all aware and endorsing it. And the really useful part of the comparative audit is that you will be able to get individualised feedback to trusts, and that's a really powerful tool when you're going to management or you're trying to change services and practice within your own trusts, to be able to go with a compelling argument as to where you lie on the spectrum of practice. And it certainly was really useful for us in our trust after the national comparative audit of blood transfusion to say that this is how badly we're doing, and can we move things forward. So that's all to come. Lastly, I just want to acknowledge and thank all the people who were heavily involved with the audit, the designing of the audit, collecting the data. Emily was on a secondment with NHSBT at the time and is now TP at King's. And Mandy, who's also here, did loads of the data trawling in Barnet. Toby, not you, but a medical student whose surname I can't remember. Brilliant midwife, Marjana, and our obstetric and obstetric anaesthetic colleagues. Thanks very much.